chronic kidney disease management beyond dialysis. I warmly and respectfully welcome our Principal Sir, Dr. P.K. Chaudhary, Superintendent Sir, Dr. Gyan Bhushan Sir, respected HODs from various departments, faculty members, non-teaching staff and students. As I have already introduced you with the topic, let me just give a brief overview. It will be dealt in 3 parts by our respective speakers. Firstly, Dr. Vinay Kumar Mathur, Senior Resident Medicine Department, will be explaining about the evaluation and management of anemia in CKD. Followed by Dr. Subodh Kumar Singh, Assistant Professor, Orthopedic Department, will be guiding us through the management of mineral bone disease in CKD. And lastly, Dr. Anand Kumar Verma Sir, Assistant Professor from Psychiatry Department, will be acknowledging us about the management of psychiatric disorders in hemodialysis dependent CKD patients. So, beginning with today's seminar, I would like to invite Dr. Sujit Sir, Academic in charge from Medicine Department, for briefly introducing us with today's topic, chronic kidney disease management beyond dialysis.
Thank you and good afternoon to all, respected Principal Sir, all faculty members, students, seniors and juniors. Today, as all we know, this is interdepartmental seminar. It means at a time 2, 3, 4 departments may be involved in this seminar. Today we have 3 learned speakers, one from medicine department, another one for ortho, and last one from psychiatry. As we know, today's topic is chronic disease management beyond dialysis. All we know that CKD incidence is increasing day by day, and data from Indian nephrologist, it is 3 to 13% in any stage of CKD patients. So first I would like to invite Dr. Vinay from medicine department, and he will take part. His topic is evaluation and management of anemia. Very important thing. Every CKD patient of anemia is very difficult to treat. The anemia of CKD very difficult to treat. Okay, my handed to Vinay.
Thank you, sir. Good afternoon, Principal Sir, our Department Head Dr. G.P. Singh Sir, our Academic in charge Dr. Sujit Sir, respected teachers, and dear colleagues and juniors. My topic for the day is evaluation and management of anemia in CKD. Starting with the definition, what is the definition of anemia according to WHO? It is defined as a hemoglobin concentration less than 13 gram per deciliter for adult males and postmenopausal women, and a hemoglobin concentration less than 12 gram per deciliter for premenopausal women. Same definition was given by the KDIGO guidelines for renal anemia. So, what are the possible causes for anemia in CKD patient? The first and most important cause is relative erythropoietin deficiency. It is the most important cause. As we know, 90% of the erythropoietin is synthesized and secreted from peritubular part of renal cortex. The second important cause is diminished RBC lifespan because of the unfavorable environment in CKD patient body. That is persistent uremic state and chronic inflammatory state. The third common cause is bleeding, that is uremic bleeding in CKD patient. Causes are iron deficiency, and other important causes are hyperthyroidism, bone marrow fibrosis, chronic inflammation between B12 and folate deficiency, blood loss during dialysis, and multiple blood samplings. Other causes may be associated comorbid conditions like hypothyroidism, hyperthyroidism, pregnancy, HIV, autoimmune disease, and uses of immunosuppressive drugs. So, when to suspect anemia in a CKD patient? 2 things are important. First is hemoglobin level. When in a CKD patient, if hemoglobin level is less than 11 gram per deciliter associated with the symptoms of anemia, then we should suspect for the anemia in CKD patient. The second is renal function. If CKD should be considered as a possible cause of anemia when the GFR is less than 60 ml per minute. Here important to mention that serum erythropoietin level is not important and should not be routinely considered for the diagnosis or the management of anemia in CKD patient. Evaluation of anemia in CKD patient. Screening is must and screening frequency depends upon the stages of CKD. It is done annually in CKD stage 1 to 3, 6 monthly in stage 4 and 3 monthly in CKD stage 5 or in stage renal disease. So what are the baseline investigation required for the evaluation? CBC with red cell indices is important. Peripheral blood smear, absolute reticulocyte count, iron profiling including serum iron, serum ferritin, total iron binding capacity and percentage transferrin saturation. Other tests may be required is stool Guaic test to rule out the GI bleeding, serum folate between B12, bone marrow aspiration and biopsy to rule out bone marrow fibrosis or other hypoproliferative conditions. Iron status. Two lab parameters are very important. The first is serum ferritin.